I think in light of the time pressures, probably move swiftly on to the final presentation, which is going to be delivered by Professor Orla Hardiman. She was appointed the first full professor of neurology in Ireland by the Trinity College, University of Dublin in 2014. Where Orla heads up the academic unit of neurology. She is a consultant neurologist at the National Neuroscience Centre of Ireland at the Beaumont Hospital in Dublin, and she leads a team of 30 researchers focusing on clinical and translational aspects of MND research. Thank you, Orla.
Thanks very much. It's great to be here. Today I'm Irish, I speak, so tá fáilte ar fad tacht go St Alban, that's Irish for welcome to Scotland. I'm very happy to be here. So I think this actually, the previous speakers actually set up my talk very well, and so, some of what I'm going to say is going to be repetitive, but I don't think that's a particular problem. I share Pam's optimism. We're almost of an age. She's much older than me, actually, but we're and she's far more successful as well. But we share optimism, I think, more so than any time in the past, and I agree with her. And I think there's not only like just before the antibiotics for TB or penicillin were identified, but also it feels like the year before we had treatments for MS, and MS is a much more difficult disease to treat. But now we have 10 or 15 drugs for MS, and it feels like that. It feels like about 20 years ago when we were just beginning to understand MS. So I think we really are on the cusp of something really exciting, and it's great to be able to talk about that, having been working in the field for over 20 years as well. And I think one of the things that came out of all of the talks was one of the big challenges that we have. I mean, I think the question that you asked, the challenge that you put to us is, why haven't we done better? And the answer is because the ALS, or motor neuron disease, is a human disease. It's not a disease that occurs normally in animals, and we have to make it in animals. And then we made all sorts of presumptions about how we could translate the findings or the successes that we had in animals back to humans. So if you're a mouse with motor neuron disease, and I don't know if there are any mice in the room here with motor neuron disease, it's your day that we can cure motor neuron disease in mice, and Pam has shown that. But the challenge is now to bring those successes with the caveats that are attached to them into humans, and that's really the challenge that we have now. Now this is the same, more or less the same slide that Brian showed, that ALS is a complicated disease. It's a combination of genes and environment in humans. So the mouse with motor neuron disease has a gene, a human gene, and that we can understand what that particular human gene is doing in that particular mouse with that particular genetic background. But it's much more complicated and messy when we try and bring this into humans, because we're much more complicated organisms, we're much messier, and we have lots of different genetic backgrounds, and that's one of the reasons why it's been difficult to bring the findings from the mouse into the humans. As Brian said, that we have a combination of gene and environment, and if you have a genetic risk, there are a number of other environmental things that might happen that might make you develop motor neuron disease. We've been very good at finding the genes, and Brian mentioned Project Mine, and that's been very, very successful. Is a gift that we'll keep on giving over the next 10 or 15 years to understand the genetic basis, not just of the familial motor neuron disease, of which there are maybe 10 or 15% of people, actually probably more like 20 or 30% if you look at all of the genes, but also the non-familial, the types of motor neuron disease that don't run in families, but where there's a genetic component to that. That's going to be complicated. We're not there yet. There's a lot of work to do. It's very challenging from a mathematical and statistical point of view. As Brian pointed out, there are billions and billions of variations, but we're getting there. That is happening. So what we have learned, and I think what has come out of the previous speakers, is that ALS, or motor neuron disease, is a syndrome. It's a disorder that we can recognise as clinicians, like pneumonia is a syndrome, or cancer is a syndrome. So it's a condition that we recognise that as doctors we can diagnose and we can treat with symptoms, that the symptomatic treatment, the things that we can do to try and make life a bit easier. But like pneumonia or like cancer, actually sorting out what's going on underneath is much more difficult, and we need the tools to do that. So I kind of agree with the statement that if we have the techniques, we can come up with the clever ideas, and we can come up with the mechanisms. So I think that we are beginning to get there, and that's what my talk is going to be about. So if we know that we can subdivide motor neuron disease, the syndrome, into the subtypes, I think that's one way forward. And I think, as Brian said, when he started as the scientific director in MNDA, it was around the same time I started in motor neuron disease, although he looks much older than me as well. But anyway, I think we did think it was one disease. I worked in Bob Brown's lab when SOD1 was identified, and I was 12 then. So we thought, oh, SOD1, we fixed the problem, we'll understand the mechanisms, and then we'll get the cure in the next 5 or 10 years. And how wrong we were. It's much more complicated than that. So the mistake that we made was that we were very presumptuous and a bit arrogant about how we thought we could progress things. And it was a very expensive form of arrogance, because it amounted to about 40 trials that we did over the last 20 years or so, all of which were negative. So that's very demoralising. And some of the reasons for that are, as I said, that the animal-based approach has been very helpful in one way, allowing us to understand the biochemistry and the biology of what's going on, but we haven't really paid enough attention to the risks of bringing the work from the animal into the human. So the likelihood in the future, and as Pam showed very elegantly in the laboratory, is that we'll have to be able to divide people into subgroups in the same way as we don't treat all pneumonias with penicillin because some people might have TB, or we don't treat all cancers with a single anti-cancer drug because there are lots of different types of cancer. And it's the same method, it's the same concept. But one of the difficulties that we have, which is also mentioned, is we're not very good yet at we don't actually have the tools yet that can take out that can help us to subdivide the different types of motor neuron disease. So we can't take a piece of the brain out and look at it and then put it back in. We can do it a little bit with stem cells, but there's a lot of complexity that we can't do there. It's kind of like looking at a play, trying to understand what's going on in the play by looking at the shadows of the actors on the wall, because we can't actually look at the play itself. We can't actually look at the full face of the actors. So we have to work really hard at a human level to build better ways of understanding how the brain works. And we also have to be better and clever about how we design our trials. And actually a lot of this meeting is going to be about those last 2 points. We'll get a lot of the basic science as well at this meeting. It's very important. But what we really need to do, and I need to do as a clinician and the other clinical people at this meeting, are to really deliver on the last 2 points there. So most of my talk is going to be on that. And I think that we won't be treating just the motor neuron and motor neuron disease. I think we'll be treating lots of different parts of motor neuron disease, because lots of different parts of the nervous system give trouble in motor neuron disease. So we can divide it into this very complicated, but phenotype, is it upper or low motor neuron, is it PLS or is it ALS? We can divide by genetics, we can divide by whether thinking is affected, we can divide by whether behavior is affected. We can use some of the newer tools that we have to see whether they're changing, like the changes in the brain, using imaging or using brainwave testing. And so then we can develop new outcome measures as well. We can divide people based on some of the characteristics that they might have, and then we can use better outcome measures, because some of the outcome measures that we're using are very antiquated. I'll talk a little bit about that. So what's the implication for this in the future trials? Well, the thing is that it is really exciting, because all of the technologies that you've heard about before my talk have allowed us to develop or to seek to test many, many new drugs. There's a lot more drugs on the horizon than there were even 5 or 10 years ago. So probably about 10 years ago, there was this concern that there was a crisis in innovation in the neuroscience, and companies weren't going to be interested in developing new drugs in neuroscience. That's just plain wrong now. There are 15 or 20 new drugs under development by industry, and there are many, many, many other drugs that would be suitable for repurposing in the stem cell laboratories. So there's a lot of opportunity here, and we shouldn't mess it up. So we don't want to mess it up anymore. So at the moment, there are 24 phase 2 trials and 4 phase 3 trials listed on clinicalgov.com, which is the the site that collects all the information about clinical trials. It's a US site around the world. So lots and lots of trials underway. But all of the trials really should be focusing on this concept of precision medicine that Pam mentioned. This is the Wikipedia definition of precision medicine, which is that it's tailored to medical treatment, the right drug for the right patient at the right time. So we've set up a consortium in Europe actually called TRICALS. It was set up by Leonard Vandenberg in Holland and myself. It's called Treatment Research Initiative to Cure ALS. It's a very clunky term because it's Dutch. They're very good scientists, but their command of English leaves much to be desired. So it's called TRICALS. He's not here. And that's some of the members of TRICALS here. We have a European consortium called ENCALS. We met, and that's in Trinity College a couple of years ago when we met. So the mission of TRICALS is exactly that. It's to get the right drug for the right patient in the right time and the right dose. And we don't have a lot of time to this because we want to be able to treat people. So that's what we want to do. So we put together a roadmap for the future to develop to get better drugs at the right time and the right patient and the right dose. So there are a number of different lanes or pathways that we've decided we're going to invest in over the next 5 years. And so I'm going to go through some of these really quickly. So we want to select people better. This is what Pam was saying with motor neuron disease or ALS is heterogeneous. It's like pneumonia in the past or like cancer in the past. So we need to get better ways of understanding the different subtypes of motor neuron disease. So we have some ways of doing that. We know that there's a lot of variation in how fast the disease progresses. And we know that some of these reasons, as Brian said, age of onset, the burden of disease and whether the brain is affected in other areas as well, whether it starts in speech and swallowing or the arms and the legs, and how fast it progresses. So we know a little bit about those things and genetic background. And we know that if we do mathematical analyses using the registers that we have, so we have one in Ireland and there's one in England, there's one in Scotland, there are a number around Europe as well, we can divide people into subgroups, and we can understand a little bit about some of the factors that lead to the subgroups, but not everything. We don't know all of the factors that make these people belong to one of those groups. We know some of them, but not all of them. So we need to understand why that is. There's a lot of more work to do in that. We know genetics are a factor. We know there are 30 genes of major effect, but there's lots of other genes that have some effect, and there are almost certainly protective genes as well, and we know that from population studies, and we've done some of this work in the Caribbean as well, showing that if you're a mixed population, you're protected from developing motor neuron disease. So why is that? What are the factors that are both making some people more prone and some people less prone? A lot of work to happen there. We're not really there yet. I think it'll take some time for us to be able to segregate people who don't have a single gene genetically, but I think it will happen. We can already select people using an algorithm or a work plan that was developed by Leonard Vandenberg's group in Holland. So you can put in a number of parameters about the condition and it'll give a probability of survival. Actually, it's not surprising that Stephen Hawking actually lived as long as he did. Using our prediction model, we would have predicted that Stephen Hawking lived as long as he did, and then he got ventilated and then he lived a lot longer. So our prediction model would have predicted Stephen Hawking's outcome as well. We also need better biobanking, so we need samples from people, like pieces of skin, so we can develop stem cells. We need to understand if there's inflammation going on. Some types of motor neuron disease seem to have evidence of inflammation in their blood, so we need to be able to collect blood samples from people. We need to be able to develop these iPS cells that our speakers have been talking about. And also we need to be able to collect brain and spine for people who sadly pass away, so that we can do further studies such as Pam showed in her presentation. We also need to recognise that motor neuron disease, even though it's called motor neuron disease, isn't just a disorder of motor neurons. And we know now that a very high proportion of people will have a little bit of thinking problem and a little bit of behavioural problem. And we can divide motor neuron disease now into people who are more likely or less likely to have thinking problem, and also more likely or less likely to have changes in their behaviour, and also the types of changes in behaviour that people might get. So not everybody gets it, but some people do. And that's also a way that we can segregate people. We need to understand why that happens, what are the factors that drive that make some people be be fine and not have any thinking problem at all, and some people to develop a dementia. So we need to understand that as well, and there are clearly factors that are doing that. So that is subtyping. We also need to develop biomarkers, ways of identifying what's going on in the brain, and sorry, that didn't. So biomarkers of disease to measure disease progression. At the moment, we have something called the ALS FRS, and you can actually do that on your iPhone. You can measure the types of disability that you have using this functional rating scale. And it's a 48-point scale, and we use these in trials all the time. But actually, when we dissect out that scale, which we've done a couple of years ago, it's not a very good scale because it's not a straight line. So that's not a particularly good outcome measure if you divide it out into subgroups. So we need to understand why that is and get better scales that we can measure outcome more accurately. So what kind of biomarkers might we want to look at? Well, we need markers of thinking, behaviour, and also markers of the overall way that the disease is progressing. So better imaging. We have good MRI scanning now, and there's actually today and tomorrow, there's a meeting of the people who are interested in brain imaging going on in Edinburgh. So there's a group of people worldwide who are building programs so that we can get better ways of imaging the brain so that we can identify the changes that happen in the brain, and we can measure that in clinical trials. So that's happening already. So we can now reliably distinguish the different parts of the brain that are affected. So it's not quite as good as taking a piece of the brain out and looking at it, but it's getting there. It's better than it was. It's better than just getting an X-ray of the chest for pneumonia. Now we should be able to define what parts of the brain are becoming more affected. So this is one set of images that we generated, just showing the differences in people who have the C9orf variant versus people who don't. But that's a couple of years old now. There are many more brain imaging studies that will allow us to understand even to a greater extent what's happening. We can also look at brainwave activity. Brainwave activity is very cheap to measure because it's just putting an EEG cap or an electroencephalograph cap on the person, and then collecting the brainwaves that are happening using mathematical tools that complex engineering-based processes. We can start measuring what's actually going on in the brain in real time, and that can tell us what's going on in terms of the parts of the brain that might be affected to a greater or lesser extent in motor neuron disease. So that can be very helpful as well, and we can also identify the sources from where these changes in the brain are happening using mathematical modelling as well. So that can give us a lot of information, again, more tools that we can use to understand both where disease is happening and how it's progressing. And those tools then we can use to segregate people out into different subgroups and also to measure the effects of drugs on the brain, which we haven't been able to do up to now. We also need better laboratory biomarkers. So we have lots of studies going on looking at things that change in the blood and the spinal fluid that might give us both a clue to how the subtypes of disease, but also clues to whether the drug is working or not. So we're working on that as well. What else do we need to do? We want to actually really have a standing army of people interested in clinical trials, and also a standing group of people who want to engage in clinical trials. So we want to develop a pan-European platform to collect data and coordinate clinical studies. And we'll even let people who are not in Europe into that as well. If you're very good, we'll let you in, even if Brexit happens. So at the moment, where the groups that are involved in trying to put this pan-European electronic patient record are listed here, and as you can see, there are a couple of sites in the UK as well. So we're working very hard to develop that as well. And the plan is, as I said, precision medicine. So this is then we'll have a number of new designer treatments already in process based on genetics. These are talked about before, but based on whether there's a drug that works with a particular genetic subtype, and there are some examples of that as well. I'm just going to, in the last 2 minutes, describe 3 studies really quickly that are already just about to start, that will be not pharma-led but investigator-led. These are repurposed drugs that we think may work but that are outside a patent or that industry isn't interested in doing, so we will do these ourselves. So one of them is it's called Lighthouse 2, and it's actually a drug that's used in AIDS because we think that there may be, in some people, a virus that would otherwise be harmless becomes reactivated, and that might be driving motor neuron disease in some people. There's another study called ADORE, which we're designing, which is the tablet form of edaravone, the tablet form of Radicot or Radicava. And so that's going to hopefully in the next year or so. And then the third is a study called Prelude, which is a study of a drug called lithium, which was used a couple of years ago, didn't see any benefit, and actually people on lithium seem to have done worse. But in fact, if you take out a subgroup of people who have a particular genetic marker, the lithium looks like it might work. So I'm not going to go through these in any great detail because I'm being told that my time is up. But these are the antisense oligonucleotides. So these are really exciting. So eventually, motor neuron disease or ALS will be segregated based on these different characteristics, like I said earlier, with different outcome measures depending on the characteristics. So the future is going to look like this. We'll have lots of different characteristics. We'll be targeting different drugs, will target different aspects of the disease. We'll have patients grouped into these different subgroups, what I call pragmatic clusters, and then we'll have clinical trials that are testing outcomes from each of these. We'll define what the outcomes want to be, and then over time we'll get a combination of new treatments. So as Pam said, it won't be just one drug, it'll be a combination of drugs with multiple actions and multiple drugs with single actions. And I think the future is very bright. The new treatments in ALS will be driven by a precision medicine approach, and I think that the better patient selection and trial design and improved outcomes that we've committed ourselves to for the next 5 years in TRICALS, I think that's where we're going to make a big difference. And I hope we'll be able to, in a couple of years' time, come back to say we've done it. We'll have the drugs. Thank you very much.